And we can start whenever you're ready. We can see your slides too.
Okay, can you see the slides? Can you hear me?
Yes, we can.
All right. Well, thank you so much for the invitation, Lucy. By the way, if you feel comfortable, I'm okay with being called Gerardo. Dr. Maupomé, we can dispense with. The most important thing we're going to do today is to provide what I think is an interesting way of looking at recruitment. And that essentially means that there is a direct relationship between how likely, how easy, or how problematic it is to recruit people based on their underrepresented minority status. And this first part of the talk is going to talk a little bit about the theory, practice, and research on how these two things are connected. And then I will start with a description of what has worked for me, that I do community-oriented research, which is slightly more complicated than recruitment for clinical trials or small-scale studies. But nevertheless, the principles, I believe, are about the same. So the first thing we need to do is to make sure that we understand that none of this really is set in stone. We're going to talk a little bit about socioeconomic gradients to place in context the discussion, and also how these social determinants of health or commercial determinants of health or industrial determinants of health create barriers for people to have better or worse health, and at the same time barriers for participation. I will describe the challenges we face and how having a better knowledge about this kind of setting, the landscape, will help inform decisions and be more successful in recruiting people. And I would like to start with this notion that the foci of research projects dictate the action. There is no a kitchen recipe that would be useful to everybody in every action. I'm going to talk primarily about how my research projects that are more interested in socioeconomic status, social class, race, and ethnicity have been addressed. But you can translate that to a great extent when you are looking at sexual orientation, for example, or schooling level, things of the like. Now, this is a very well-known image that I suppose that you have seen in the past, but the most interesting thing about this fairly old image by Dahlgren and Whitehead is that they made a point that this is like an onion. So you have at the core those persons that are somewhat made up, shaped by age, sex, and constitutional factors. And this is actually something I will also speak to genetics. So because there is something that is to the individual level that will create the sort of central part of the onion. Then the choices of individual lifestyle factors, that you have to be careful here, because the choices are not necessarily choices that you take voluntarily 100% on your own volition, your own decision, but it's like doing exercise, being able to do exercise, having green spaces where you can do exercise, having spare time to actually do exercise, or having a person that can take care of the kids while you're doing exercise. So it is really a matter of choices, but those choices are greatly determined by options in the next layer of the onion, the social and community networks. This is my area of research, well, one of my areas of research, but certainly for minority health. I use social networks as a way to understand which aspects of the individual life are supported or undermined by having networks with certain characteristics. For example, being a very recent immigrant with no connections to a new space because you arrived because you were an asylum seeker will create that kind of very primitive network that you need to start developing over time so you can have more assets to get a ride to go to a good grocery store instead of walking to the C-store, getting an opportunity to go to a dental appointment. You don't have a driver's license, so you need some help there. And the next layer of the onion are the living and working conditions that things start becoming less clinical and far more social, cultural, economic, when you look at what are the policies, what I really call here the social determinants of health. I don't think that proxies of poverty are really good representation of social determinants of health. They are proxy descriptions of poverty or social disadvantage. But when we look at the social determinants of health, we look at what are the agricultural and food production policies in the country, what are the actual opportunities for education in your group, what is the work environment, whether it is protective or not, whether you have an opportunity to get better conditions for work, and so on and so forth. The same goes for unemployment, work sanitation, healthcare services, and housing. And at the end of all of these, you have the general socioeconomic, cultural, and environmental conditions. And this will be the outer layer of the onion. When we have this complex scenario, we realize that what the NIH and federal funding mechanisms are trying to do is to propose that people should have the same opportunity to participate, and there are good reasons for that. So the plan for diversity, equity, and inclusion really is about finding, recruiting, and retaining participants in studies, because it's not only the matter of being equitable in terms of or as equitable as possible for participation, but it also improves science, because there are many good reasons, like you do represent in the findings of the research something that it really applies to all groups, not only those that are easier to recruit into a study. Now, I want to make sure that we go to one of the basic premises I indicated before. The reasons for non-participation overlap with factors that are embodied in the underrepresented minority status. So these things are not disconnected. And I will say that basically it's how much control you have over your life. We'll come back to this. Now let's look at the minority statuses. Again, I said that I'm going to be working primarily race, ethnicity, social class, and socioeconomic status, but this applies to many other things like gender identity. And I want to borrow from the COVID-19 example, because it was really like a cauldron of so many things happening in such an accelerated way that we public health people just were pelt from every single direction, trying to make sense of the many interesting things that was happening with a pandemic. I mean, it sounds a little bit dark to say interesting things, but really, I mean, this is one of those one in a lifetime, or maybe hopefully just one in a lifetime in my case, to see this kind of epidemic and be able to understand how these different factors are affecting people in general. Now, it was pretty clear that COVID-19 was impacting communities of color far more severely from the beginning of the epidemic. And this kind of situation continued as the pandemic unfolded. And this inequity really had to do with basic issues such as the unequal allocation of power and resources, which is really another way of saying social disadvantage, and the structural inequities that organize the distribution of power and resources differentially across boundaries of race or any kind of minority status that you want to say, social class, sexual orientation, and so on, so forth. Now, the root causes of this COVID-19 really are going to be explained a little while. We have already seen some of that. But when they are manifested of that higher impact in brown and Black people, you find that these members of society have a higher likelihood of not having bank accounts, being unbanked, smaller cash reserves, more likely to be unemployed, even more during the pandemic, more likely to be in frontline jobs, in particular Hispanics, less likely to have the flexibility to protect yourself by working remotely. Like in my case, it was relatively easy to do that. Whereas if you are cleaning offices or flipping burgers in McDonald's, your chances of working remotely are pretty much zilch. And then you have the experiences in such a way that you find that COVID-19 was the logical example how things can get really nasty very quickly, because the room for maneuver and the control you have over your life is much lower. Now, the challenges we face in health and in healthcare has to do with many interpretations. This one is an interesting one and also quite often mentioned, is that we have the element of equality, equity, and barrier removal. Usually the distinction here is made between equality and equity, because let's say that you provide some support, the boxes supporting all of these people watching the baseball game from afar. And when you give all of them exactly the same support, you find that some of them improve, like the child in the middle, but the child on the right-hand side, despite the support, doesn't get what she will need to see the baseball game. When you approach an equity-based approach, you give supports to the extent that they are needed. And for example, in this case, do not waste in the really tall child a support that may be better applied and more useful when you have a younger child on the right-hand side. What I will argue is that if you remove the barriers, which is the case, in this case is the fence, you have a different type of approach and different type of result. Now, the issue with, let's use the example of the water polluted with lead in Flint, Michigan. You can give water to everybody, but then the taller child would probably have better quality resources in terms of water, the ability to buy water, whereas the smallest one doesn't have that, even though if you provide some bottled water, limited bottled water. You attain a better measure of equality or equity when you have the youngest child, the most disadvantaged child, receiving more of the water that will come from a safe supply, as opposed to just simply make do with whatever they can get in the poor residential area where most likely this person is. In an ideal world, you will remove this barrier by making sure that the entire Flint, Michigan water supplies are free of lead. That would be really when you attain an issue of creating true similarity of circumstances across different groups. Now, the challenges we face in participation of underrepresented minorities is not too different from the same scheme, because you have some on the left-hand side. Some of your potential participants are unable to be reached because they lack the communication, they lack the time, you don't know how to speak the language, they don't know how to speak English, and there's a whole bunch of complications that really put them out of reach. And this is where the effort by the federal funding is, well, you have to overcome those barriers. And if we move to the middle, which is invest to expand, let me see if I can remove this thing. I don't know how to work. This may be better. You invest to expand the access in the middle slide, and what you have, for example, is that in the younger child, the one with the lowest likelihood of being part of the study, you say, okay, we're going to send the interviewers and the biospecimen collectors to your home. So then you have a mom that doesn't have to be concerned about transporting herself and 2 or 3 kids to a place where she needs to find where to go at the right time, to make sure that the children are not being a nuisance. But if you send a mobile group that is going to collect by phlebotomy some blood, and you're going to do the interview at home, then this barrier really is overcome because you're reaching out and making things simpler for them. And again, in an ideal world, there should be no barriers, and without removal, there will be increased participation. That, unfortunately, is not the case with many examples of research in the US, simply because we are a highly heterogeneous society. Now, if we have to summarize how the COVID-19 situation was affecting, having the largest impacts, it was easy to see in this July-August 22 data collection by the Robert Wood Johnson Foundation, NPR, and the School of Public Health in Harvard. They found that some of these limitations grew very rapidly because the buffering effect of what resources they had saved to meet challenges was a lot smaller. For example, in New York City, 1 in 3 households report using up all or most savings since the beginning of COVID-19. In LA, 1 in 4 households miss or delay paying major bills to buy food. Chicago, 1 in 3 households do not have high-speed internet at home. So essentially, the ability to work or to learn remotely is severely limited. And in Houston, we had that half of the household had experienced serious problems caring for their children. So this is the kind of thing that will tell you that it's not that people don't want to participate in the study. Still, we all have to make sure that we make inviting the kind of opportunity to be in the study. But at the same time, we need to be cognizant of the fact that some people have lower likelihood of participating because they have fewer opportunities to control their life. Now, this is something that is discussed very nicely in something called the theory of fundamental causes. And basically, these Lincoln Phelan guys, they say that there is a greater relationship between socioeconomic status, social disadvantage, and health and mortality. But it's not that the two things are connected. There are biological mechanisms between those two. But the truth of the matter is that you need to see how this disadvantage has evolved across different layers of employment, having a bank account, having the opportunity to control your schedule for work and things like that. But all of these come from larger perspectives, a larger landscape, and you have to look at it over the course of a lifetime. So this is where you have the life course epidemiology approach. Now, despite the ability to create a lot of health opportunities, it is something that is, at least in the US, very closely linked to the ability to purchase those resources, because you have a job that has good medical insurance, has medical insurance, you have the opportunity to go and see a doctor when you need to do that, and so on and so forth. But I will close this part by saying that participation in research resembles how much control you have over your life. Because at the end of the day, this is the kind of thing that will really govern why people participate and why they don't, for the most part, of course. Now, how can we look at decisions to barriers to participation? We know, and this is something that has been around for quite some time, there is an imbalance of minority representation. This is an ethnic minority type of description between whites that are more likely to be part of a study above and beyond the representation in the US population. Blacks have slightly higher than what the situation they have, but still the participation is low. And then you have Hispanics that are usually not participating very well at all. Now, I am a father. And by that, I mean that I have a card that says I can tell dad jokes, okay? So these are dad jokes. I'm sorry that you're going to be the guinea pigs of this, but I'm trying to get my act together. And how do you ameliorate these barriers? Well, you call 1-800-GET-URMS and your life is sorted out. Or you contact Amazon and they have dehydrated participants. So you get your book, you just put some water, shake it, and then you have the participant. Or have some basic assumptions that are probably incorrect, that we can easily reuse ideas and approaches across all of these groups. And it may take, it's really quick to do this kind of thing. Now, the reality of the matter is that there's not one approach that will work for everybody. And again, we go back to the issue of structural and gender-specific issues or barriers that will make difficult for your participant to be part of a study. How do we deal with this? Well, this is the reports that were sent by a group of clinical trialists that came up with the idea that you have to identify the barriers, limit access to resources, having health issues, so on and so forth. Frame conversation effectively. You need to be there and appear present and relevant, and co-create best practices. Identify what are the approaches that you will be able to use to engage the community. Do they exist? Do they exist but have not made it to a high level of adherence implementation? Can you do that given the time and financial constraints you may have? So let's look at each one of these carefully. The social, economic, and health issues matter probably as much as the institutional structural issues and barriers that have developed over a long period of time. If you are trying to recruit people that do not have an easy means of transportation, except when they need to do something really exceptional. I don't have a driver's license. I don't know how to drive. I'm afraid of driving in Indianapolis because I don't know the place. So that participant depends on the cousin that is going to drive her to the appointment for research, unless you do something to overcome that barrier. Now, how do you identify those barriers? Well, identify the root causes, which I think is the one thing that is interesting from the previous slides, because it tells you that people are not evil. It's not that they don't want to participate, it's that they have a highly coherent model of how to run their lives. And sometimes they have to let go of those opportunities, or they don't want to even talk about them because the effort to participate in a study is simply too high to do something that will create a real opportunity, a realistic opportunity for that person to participate in research. All of this promotes shared governance of solutions, communicate stakeholders. This is something that you need to do, what like me are doing mostly the community type of research and in large numbers. I need to follow them over time. I understand that some of you are project managers with smaller endeavors that are nevertheless very important because they need to have a retention plan. They're going to visit 1, 2, 3 times. You're going to collect biospecimens, and that puts off some people say, no, not blood. And that's really the simplest. I mean, a good example is convincing a person to donate breast tissue for the bank. So these things really need to be placed in a good way, under a good light to be effective. Now, those best practices really is, from the sponsor perspective, partner with the communities early and find out what can you do. Develop accessible site networks so you can actually allow people to come and access whenever they're ready to access your offer. And then make sure that there is a reinforcement of how you're going to do this. And there is a plan that is going to make things happen. In the case of, I'm losing my, okay, yeah. The site, and this is something that's going to be explained again in the next few slides. You have to build trust. Because if you just parachute into a group of people and say, hey, I'm from IPY and I have this great idea that you need to take advantage of because it's important to me. In reality, you need to make sure that you partner with community stakeholders, provide information, and make sure that if you can hire the locals, so to speak, the natives, to speak for you and to be part of the marketing scheme, you're in a much better place. I have done that certainly with a lot of Hispanics endeavors and American Indians in a former lifetime when I was working on the West Coast. Now, these are my nuggets of wisdom, which I hope they are wisdom and not just things pie in the sky. But the practical tools here is that the focus of the research project takes the action. How many people do you need? When do you need them? Do you need to retain them? Is it a one-off kind of thing? How invasive is the participation in terms of data collection? All of these things are important. Then you can start tweaking with the rest of the list, and things that have worked well for me in fairly disadvantaged conditions is that I meet people where they are. You create an image. You show up, you're nice, you bring a positive message, and you look like, you know, this is an important thing. I'm Dr. Maupomé, and let me tell you what, this is an important thing. You need to be there, be known, and be useful. In some cases, you have to help people attain goals or have routes for things that they did not that I do not contemplating my research. A classical example is my project managers will get calls to say, how do I get an affordable English classes when I was working with Hispanics? Well, let me find out, because obviously this is something that is not in your research plan, but you know that you need to be useful. And by that, you become a household name, and you start getting some of the penetration you need to make sure that there is an opportunity to liaise with the locals. The community and academic ally boards are a great idea, but they tend to be a bit more reserved in terms of the enthusiasm because they are not a panacea. Use social media to remain visible. In my case, that means that I have to have young project managers that tell me what to do with tweets and Instagram and things of the like that. I don't know to do any of that, and I don't particularly care, to be honest with you, but they know everything. So they have all of these platforms, they have all the TikToks, all of that kind of thing, where we can send snippets of information and make sure that we are present in the life of the community. When I say that we meet where they are, is what I was trying to say, that if you have a real challenge to recruit participants for whom attending the Institute of Neurology and finding the way around that until they reach the lab or the interview place, you really need to make it easy to participate. And obviously, the idea here is you learn what is it that you need to do to make it easy for them to participate by talking with community members. Now, we all know that recruiting community poses challenges. The complexity, the language, in some cases, the community is underground because the sexual orientation or the documented status are not things that they would like to reveal to the outside world. I have found that this is something that the more you understand the community and the limitations of the maneuver margin they have, will tell you a lot how to design your recruitment. I have found that a map, literally a geographic map of where the target is and where the influential agencies are: a parish, a temple, a community organization, a business that is commonly attended by your target group. I think that will tell you more or less how you go about creating areas of influence. And I will always make the point that you approach the leaders out of respect and to get a green light. But I put most of the effort befriending the mid-level managers, because those are the people that make things happen. When you're organizing real contact with potential participants, if you are, for example, in a church, I will tell you very specifically, don't talk with the archdiocese, because they don't care and they're too high up and they don't make things happen. Talk with the priest, because the priest will tell you whether you can be accepted in that area. You become charming. You say, oh, this is fantastic, Father Valdez. This is excellent. But it is the person, usually lay workers, who are in my case, the Hispanic ministry or the special needs ministry, that will tell you how to do things and how they make things happen. I make the point of no cold calls, and I always survive with things to leave behind, so that they remind people and they bring plenty of visuals, booklets, flyers, make the case, but plant the seeds. And of course, you need to follow up very pointedly to make sure that when they say, call me next week, because I think that you can come and make a presentation during the parish announcements, then you have to be there and you make sure that you are included in the list of people that are going to talk after the Mass. And of course, be mindful of time and effort commitments for what I was saying about transportation, child minding, and so on. Now, I have talked about the first item, that community ally advisory reports are good, but they are not the only thing that you need. And primarily the problem there is that people who agree to be in the community advisory board, in some cases, they are very committed, very enthusiastic, but they do not know the community well enough or don't have the leverage to move people in your direction. So that is a good thing to have. And if it works to apply leverage, that's excellent. But if the only thing you get is knowledge, that's good enough. The most important thing is that do not add work burden to your community counterparts. And if you do, pay them for time and expertise, and certainly with respect. And you have to be upfront and clear on the deliverables and the compensation that are expected. Make all of these materials easily accessible. And most importantly, do not lead people to believe that they're going to get more than what you really can deliver. So do not overpromise or underdeliver. And the big question is, tell me, why should they help you? If you can answer that question, you're probably going to succeed in doing your recruitment. And here I pass the baton at exactly 2:30 in the afternoon to Gina. Gina, do you want me to stop sharing and you put yours?
If you don't mind, it might be smoother if you just leave yours up.
Good. Carry on.
All right. Thank you, Gerardo. And so I work with Gerardo at the Community Health Partnerships Program, the Indiana CTSI. I know some of you on the call are familiar with the Indiana CTSI, but I thought I'd just do a quick overview for those of you that may work in different departments. We're a partnership officially between IU, Purdue, Notre Dame, and also with many others you can see on that wheel. I won't call them all out, but we work in partnership in order to help make Indiana healthier, primarily through the lens of research. Go ahead. Next slide. Can advance it, Gerardo. Oh, thank you. Okay, and so Community Health Partnerships is just one program within Indiana CTSI, and that's the one that I'm going to focus on today. And I do want to emphasize before I go on to tell you about the services of Community Health Partnerships that Gerardo just outlined a ton of really significant barriers using that onion diagram at very different levels of an individual's participation in your study. So please don't believe for even a second that the programs and services I'm going to outline right now that we offer are going to be the one-size-fits-all solution to some of the challenges Gerardo just outlined, but we are there to help think through some of those questions which Gerardo outlined as like prompts to think through in your study design and what you're asking them to do and barriers they may be facing and why they should help you, his ending question there. So we're a program to help support you in thinking through what's going to be unique every time in partnering with your community partners. And so as a program, we bring community and university partners together on research, working through the lenses of health partnerships and bringing science to life. Next slide. And so we are a free service in terms of consultation. So we have partners from across the state of Indiana, from both community organizations and academic institutions, could be IU, Purdue, Notre Dame, also ISU, and University of Indianapolis. Anyway, any campus across Ivy Tech, academics across the state as well. And so our network is over 500 individuals wide. And in that, there's expertise in lots of areas, as you may expect, different fields of health research and community expertise, different counties of the state, rural, urban, different demographics represented. And so that's a real strength, that we have connections to different partners who may help brainstorm with you or may be a good partner for your research as well. And so as a program, Community Health Partnerships offers consultations to help think through who may be good partners in your efforts, and then could help with an introduction to that if it seems like a good fit. We'd also welcome any of you to join that network, which I'm going to show you how to do that later. We have professional development opportunities as well. So similar to like the talk we're giving right now, we have conferences that are short, brief, 1 hour, or full day conferences. So coming up in October, we have a full community engagement event that you all are welcome to attend. And then tools and services I'm going to outline now. Okay, it's coming up here. Okay, so one that you may have heard of already, either through this setting or otherwise, All In for Health. It sort of straddles both recruitment efforts of the CTSI and engagement. So from an engagement lens, for the public or the people that you're trying to recruit, it's a way for them to hear about the research going on in Indiana, to have a voice in what they would value out of a research study, a way to hear about studies you're offering, get connected to the findings that are coming out of this research, and potentially volunteering or signing up to be a part of them. On the researcher side, it's All In for Health offers a way for you to promote your recruitment efforts, talk directly to the public about your study, and share that volunteer opportunity with them. So many of you probably know Brenda Hudson, who manages the statewide volunteer research network. And so I partner with her on this, and it's a way to talk directly to people about your research opportunities and why they should get involved or might want to get involved. Another initiative we have within Community Health Partnerships is Connections in Health. Connections in Health is actually made up of 3 statewide health coalitions. One's focused on asthma, one is on cardiovascular disease and diabetes, and another on obesity and nutrition and exercise. And we partner with, you can see listed there, Purdue Extension very closely, the IU Simon Cancer Center also. And these are statewide initiatives that use coalition or locally based approaches to address these chronic disease issues. So we have community members in all 92 counties that are part of these groups. And so if a study that you're running focuses on any of these chronic disease areas, or you think coalitions may be a good partner in your project, we can get you connected to the Connections in Health team. Or I should say, they also meet regularly as a coalition, so maybe something to get involved with from a focus and networking perspective as well. Okay, next. We also offer pilot funds to do community engaged research. There's actually 2 different mechanisms of funding. Our smaller one, the second one listed here, is the Trailblazer Planning Grant. It's $5,000 and is really just a small amount of funding to help that relationship building begin. So Gerardo talked a lot about meeting your partners where they are, getting to know each other, building that long-term relationship. And the Trailblazer Planning Grant would allow you to do that. If you identify somebody, say, hey, I think we're going to work together for a long time. Let's spend some time getting to learn about each other, maybe sharing some meals together, going to conferences together, things like this. That would help support those efforts. The Trailblazer Award is a little bit larger. It's $25,000 and would allow you to do sort of your first step research together. So you've identified an area of shared value and say, hey, I think we're ready for a project. And so the Trailblazer Award could help fund that project. We also have a group within CHEP called Research Jam. This was one of the things Gerardo listed as a potential way to involve community members around your research topic. So our design team is called Research Jam, and we use human-centered design research to partner with community members with the lived experience and whatever you're trying to explore to come together and give their input, their perspective, their expertise on that matter to help inform whatever the research question is. Often this is a recruitment strategy. So say an investigator is having trouble reaching a certain group or isn't meeting recruitment goals, they could gather a group of individuals to help them think through what could make their communication plan stronger, or where they should be sharing their messages, or help them answer the question, why should they help? Why should they participate, right? That key question Gerardo presented. So there's another option. And then finally, just to, I know I went over a lot here, but to stay connected to CHEP, learn, we have a monthly newsletter, a really brief one. So you could join our network here. I'm hoping the slides will be shared and you can click on the link. Otherwise, you can find it on our website, and you'll automatically be able to get updates on all those initiatives outlined. It'll also allow you to get in contact with either of us for that consultation piece that I described at the top. And so at this time, Gerardo and I are open to questions, comments, any sort of feedback you have. Thank you.
Just a quick point. I put in the chat two pieces that exemplify what I have done in the past to recruit people for studies. A lot of these studies were community explorations, community assessments. So it may not necessarily be directly translatable to clinical trials, for example, but they provide a good example of how to do this. The first one is, if you go to the first message in the chat, you have a web link. If you click on it, then it will take you to the paper. So you can print it, download it, do whatever you want. So if you want to copy those two items, it will give you examples of what I have done that have worked for me, and it will give you some idea of how to go about. Obviously, in this case, I'm talking specifically of the Hispanic community, but I think that there will be some other options if you look around. I didn't think that American Indians will be particularly relevant here, but this is something that you can use for inspiration, if anything. So, Lucy, we are now ready for questions, and I don't know if there's anything else that you would like to us to address.
Great, thanks. Let's see if there's any questions right now. I think I don't see any that are specific here. Yes, the slides. If you guys would send me the slides, then I'll send them out to the group, and then that way everyone can have the slides.
And I believe this is recorded, right?
It is recorded, yeah. And so folks can view the recording on pardon me, on the Ultra page that the channel that we have. And it's on the announcement, on your announcement, there's a link on that announcement.
Lucy, it's Brenda.
Yes,
Can I ask a question?
absolutely.
Gerardo, what if you were looking to identify like these community champions that could be, part of your project that you're paying to be on that? What do you think are some of the best ways to identify community folks that would be part of our academic mission and projects?
I usually ask people who are in the midst of that group. For example, I make an appointment to talk with the priest in a parish. And then I ask him, hey, who do you think I should have advising this effort? So, well, in the case of Hispanics, I can tell you that 15 years ago, 12 years ago, it was far more difficult to send remittances to Latin America and to Mexico. So there was one business that it was pretty much frequented by everybody, because it just so happened that they have designed how to get the money from the sender here, and then we'll create the money someplace in Western Mexico. That was a natural hub. Priests are usually quite good to do that. They will delegate most likely to the next level. But again, you have to be careful what this is about, because you can ask about certain things in terms of helping with cardiovascular health. But if you're trying to get birth control, you don't ask the priest. Yeah, you need to figure out exactly how you're going to put these messages out and figure out who will be the person. I would caution, though, that one of the problems with going out shopping in the open market for helpers is that some people really are trying to find, I won't say a mission, but something to do. And they are very keen on talking and having conversations. You will soon find out how much traction they have. But at the beginning, just explore really what is that person doing that will put him or her in a good position to contact people. Classical example is you ask who will provide health advice to the locals in that parish. And it turns out that Doña Maria is a nurse practitioner from Mexico who doesn't have a license here, but whenever any kind of family has a problem, they contact Doña Maria and say, do you think that this is a real problem? Where should I go? What do you think I should do? So it really acts like a conduit to connect parts of the community. That kind of person is extremely useful.
And does CHEP have a any kind of connection, like so if I want to find somebody in a community church or whatever, right, is there a list of folks that would be available to connect with, or should we kind of try to find our own?
So we do have the statewide network that I mentioned earlier, and it does have community partners in there. Now they are part of our network for work that they've done in the past. So it could be that they were a Trailblazer awardee from one of those projects I talked about, the funding we offer to do partnerships, or maybe they've worked with Gerardo on a project he's done in the past, or maybe they're part of the coalitions. So they've joined the network for a reason that's fit before. So we may be able to do an introduction, but it really gets down to like whether they're going to be a good match for the project at hand. I think of what part of what Gerardo was talking about too. And went into the very specific question, if we have churches in our network, I would have to check. We have done congregation work, faith-based work, initiatives through a part of our work called the Monon Collaborative. If you've heard that before, they worked with, I think, 13 congregations in the Indianapolis area. But each church is also going to be different. So I think that we could help brainstorm, but it would probably be better to think about which church or parish or even neighborhood is the best for the project you're working on, and then come to us rather than us saying, well, we have this person, let's see if they work, so we can help narrow it down, and we may have a partnership with them, but I wouldn't let that limit who you think about.
Thank you.
And there is no substitute for you to walk the area. You remember that I was trying to collect some information from East Chicago. And I just arrived there. Had my son, a teenager, with me for whatever reason. We went to different places. We actually had lunch in one of the local restaurants, and you strike a conversation. You look for the church, you look for who's doing what, and you ask polite questions, but you get an idea what that situation is. The more you are familiar with the mechanics of the place, the better off you're going to be in identifying who your person is. That has the added benefit, at least for me, that I keep track of where the good tacos remain in Central Indiana, because I go to all of these places and I have some tacos. While I ask the taco guy, okay, what's happening here? Which is the nearest school? What are the local temples with a large number of people? So on and so forth. So it is usually a good idea. Also, Spanish masses, in my case, the Spanish mass usually have a lot of families. So they often have breakfasts or brunches that the food is sold, so that the proceedings of the sale goes to the church. So there are different families rotating, and they have one of these brunches every month, every couple of months. Just swing by, buy your brunch, sit at the table, and talk with people, and that helps.
Great, thank you. Anyone else have any questions?
I think I would just add to what we've been saying. For the projects where it doesn't make sense to do some of that in-person stuff, or maybe you're limited or don't have time, then probably the best avenue would be to try to connect with Brenda with the On for Health volunteer network. That is a list of people that have said, I'm open to research opportunities. And that's more, I think, what you're saying about, like, is there a connection with the direct connection to that team or that person? So we do have that. I think that the long-term partnerships with the organizations that takes more time, and well, you can hear what Gerardo is saying about building those relationships over time and getting there eventually.
Yeah, and at some point in time, you have to also make sure that you understand what are the specific preferences. I don't think that we have a one-size-fits-all in terms of you want to participate in research. No, you participate in research for two reasons. One is the compensation that is sufficiently meaningful for you to be attracted to that. We are in IRB, we're supposed to not do that in order to avoid coercion. The reality of the matter is that is not true. I mean, it's as simple as that. Particularly the poorer the person is, the more likely they want the compensation. That's number one. And number two is the second biggest element of participating, is that you see a liability, or you can relate personally to something. If you say, oh, mom died of cervical cancer last year, we had this study on Papa Nicolas. Oh, well, I want to participate. Or smoking cessation, or alcohol intake, or depression in teenagers. All of those things need to resonate with the potential participant, because no one is going to participate in everything. They need to see a personal connection there. And of course, this is something that needs to be taken into account, so you are not, so to speak, polluting the pool of participants. But you need to be explicit why you're doing this, who is going to benefit from it, what kind of things are available, what is it that you can offer, and what is it that you cannot deliver.
Great. Just an update for text attendance. It is now working. Just got the email to say they fixed the issue. So the number is 83396. Again, 83396 that you text to the CME office to obtain your CMEs.
Hey, Lucy, I just wanted to go, the recruitment workshop is going to be 4 hours, not 2. So
Sorry.
It's like half a day.
Yeah, I apologize. I forgot. It's been a couple weeks since we talked about it, right?
That's right.
Okay. Well, thank you, Geraldo and Gina. This was great information. I think all of us, I know I learned quite a bit, so it was wonderful. I appreciate all your efforts here, and thanks so much.
Thank you so much for inviting us. Much appreciated.
Thank you.
Take care.
Bye, everyone.
Lucy, do you have